It's so wonderful to have this panel here, to have such a distinguished group of guests in this beautiful setting. Um, so I want to welcome you all to this setting a new agenda for Medicare's post-acute care payment policy. I'm Dan Polsky, Director of the Hopkins Business of Health Initiative. I'm the host of today's event. So first, I want to thank the funders of this event, Johns Hopkins University and the Nexus Award Initiative. This event is part of our the Hopkins Business of Health Initiative's Future of Healthcare Delivery series, which is supported by this Nexus Award. The previous sessions for this series have explored cultivating trust in healthcare and primary care reform, aligning payment, policy, and innovation. So today we turn to another critical and complex issue, shaping the future of healthcare delivery, post-acute care. Medicare payment policy is a powerful tool for promoting effective and efficient post-acute care. Yet despite decades of incremental reform, major challenges remain. And as Medicare Advantage continues to reshape how beneficiaries receive and providers deliver post-acute care services, there is an urgent need to take a hard look at payment policy and set a new agenda, one that balances spending controls with equitable, high-quality care. We have the good fortune to have the people here that are going to solve this problem for us in the next hour and 20 minutes. I should quit talking now so that they can solve the problem. The time is ticking. But I'd like to introduce our distinguished panelists. David Grabowski is a professor of healthcare policy at the Harvard Medical School. He's a leading health economist. His work focuses on long-term and post-acute care. He's a member of the National Academy of Medicine. He's testified before Congress several times and served for 6 years on the Medicare Payment Advisory Commission, MedPAC. Next, I'd like to introduce Ann Deutsch, who's a senior research public health analyst at RTI, splits her time at Northwestern University, Feinberg School of Medicine, has an appointment at the Shirley Ryan Ability Lab as well. Ann is a nurse and epidemiologist. Her work has been critical to the development and implementation of post-acute care quality measures and Medicare payment models. Next, I'd like to introduce Tamara Konecka, the Lewis Block Professor of Public Health Sciences at the University of Chicago. Dr. Konecka is an internationally recognized expert in the economics of long-term and post-acute care. He's known for research on payment incentives, quality reporting, and nursing home policy. She currently serves on MedPAC and is editor-in-chief of Medical Care Research and Review. And last but certainly not least, our moderator, Catherine Linehan. She's the Medicare Policy Director here at the Center for Health Systems and Policy Modeling at the Johns Hopkins Bloomberg School of Public Health. Her career spans work on Medicare payment and delivery system reforms with a focus on post-acute care policy, the theme throughout all of our speakers. As principal policy analyst at MedPAC, before she came here, she led analysis on skilled nursing facilities, long-term care hospitals, and site-neutral payment reform. So before we begin, we're just about to begin here. One more little statement here. You might notice note cards on your seats. So please write down any questions. We'll collect them before the Q&A portion of the program. And now I'm going to turn it over to our moderator, Catherine Linehan.
Okay. Okay. Hi, everybody. I'm Catherine Linehan. I'm delighted that you're all here to talk about post-acute care. I'm going to just do a little table setting, and then we'll get into the panel. So post-acute care, or PAC, which I'm going to say many times, sorry if that annoys you, refers to the short-term skilled services patients receive after a hospitalization. It supports recovery with the goal of helping people regain or maintain function. It's part of the care continuum for millions of Medicare beneficiaries at a critical stage in their recovery. About 41% of Medicare beneficiaries that are hospitalized have a post-acute care discharge. It allows Post-acute care allows hospitals to discharge patients safely and plays a key role in preventing readmissions. As Dan alluded to, over the past decade, there have been concerns about incentives in Medicare's PPSs, and it's prompted some policy changes. First, traditional Medicare's PPSs for PAC have been refined to reduce incentives to get paid more to do more. Value-based payment has also been implemented in some settings, but at the same time, momentum around site-neutral payments for post-acute care, which was a very heady topic at one point, has faded. Alternative payment models built using traditional Medicare payment systems and rates have been shown to reduce post-acute care use in some cases, but scaling these seems like it's more of a long-term project. And growth in Medicare Advantage enrollment has reshaped care delivery. MA plans may use prior authorization to manage admissions and length of stay in post-acute care and may restrict their provider networks to manage that care. Compared with traditional Medicare beneficiaries, we have more limited insight into how MA enrollees use post-acute care and how MA plans pay post-acute care providers. So today's panel brings us all together to take stock of what we know, to identify some evidence gaps, and to chart some priorities for the future direction of PAC policy. Before we get into our conversation, I'm gonna take a few minutes to provide some context. So this is the only slide portion of the program. Post-acute care is provided in multiple settings to Medicare beneficiaries: skilled nursing facilities, home health agencies, inpatient rehabilitation facilities, and long-term care hospitals. Each of these settings has its own Medicare payment system and beneficiary and provider criteria. But there can be overlap in the patients across settings, and depending on the setting where a beneficiary is treated, Medicare and the beneficiary can face very different costs. In total, traditional Medicare spending on these settings was about $60 billion in 2023. This slide highlights how traditional Medicare spending, users, and providers are distributed across these four settings. SNF and home health by far account for the most use in spending. IRF and LTAC, inpatient rehabilitation facilities and long-term care hospitals, I'm going to pronounce them that way, otherwise we'll be here all day, are licensed as hospitals and have higher per stay costs and are used less, and there are fewer of them. The changes in nominal PAC spending per traditional Medicare beneficiary between 2014 and 2023 are shown on this slide. SNF spending per traditional Medicare beneficiary has increased. Home health was pretty flat, slight decrease. IRF increased more than other settings, and LTAC spending per traditional Medicare beneficiaries fell. On net, PAC spending per capita ticked up about 4.4% in this period. Compared to the previous decade, following the implementation of the PPSs, this is relatively slow growth. Next, I want to talk about how Medicare's aggregate payments compare to aggregate costs of caring for Medicare-covered cases, starting with SNFs. Traditional Medicare payments exceed SNFs costs. I show 5 years of data here, but SNF Medicare margins have been at least 10% for 2 decades. In 2023, MedPAC found that freestanding SNFs have Medicare margins of nearly 22%. And just to note that MedPAC changed their methods slightly about how they compute margins. So part of the increase between 2020 and 2021 is attributable to that, but not all of it. And then this slide, or this right side of the slide, shows the all-payer margins for SNFs. So this is all payers, all patients. Those are around break even. SNF care is provided in nursing homes that provide long-term care that Medicare does not cover. Medicare-covered stays are only a small part of most nursing homes' total business. The all-payer margin largely reflects profits on long-stay nursing home patients. Similar to SNFs, home health agencies and IRFs also report strong Medicare margins and have for years. Their all-payer margins are higher than SNFs. Medicare is a larger share of these providers' business than it is in nursing homes. And a note about these aggregate margins for post-acute care providers: this is, all payments, all costs for all providers. Within each setting, providers report a wide range of margin, Medicare and total all-payer margins. And finally, here are the Medicare and all-payer margins for PAC settings you saw on the previous slide, with margins for acute care hospitals paid under the IPPS for context. You can see that the PAC settings have higher Medicare margins than hospitals, but all-payer margins among these settings, the differences are a lot narrower. So now let's get into our panel discussion. I'm going to sit in my chair and talk to the panelists. Okay. So my first question is for David. Your research has examined how post-acute care providers respond to payment incentives, and after years of concern about incentives in traditional Medicare's payments for SNFs and home health agencies, CMS implemented new payment systems, the provider-driven payment model and the provider-driven groupings model. They introduced those about 6 years ago. And from your perspective, what have these models improved, and where have they fallen short or created new challenges?
Great. Well, first, thank you, Catherine, for including me today in this meeting. And thank you for organizing it. It's such an important topic. What a great question to kick us off. The patient-driven groupings model and the patient-driven payment model really flipped home health and skilled nursing facility payment on their head. Historically, those two sectors have provided strong incentives through Medicare to provide therapy. The more therapy you provide, the more you get paid. And so guess what? There was lots and lots of therapy. And so a big part of the idea in introducing the PDGM and the PDPM was to basically right-size therapy and shift the incentives. And so rather than paying based on therapy, and really it's now paying based on patient characteristics. And so the good news, Catherine, to the first part of this is that we have right-sized therapy. Before, we had these payment cliffs, basically. If you delivered 600 minutes of therapy in a week, and think about how many hours of therapy that is, or 720 minutes, you got a huge bump in payment. Not surprisingly, you had this interesting distribution where you had these huge spikes at 600 and 720. Guess what the distribution looks like post-PDPM? Perfectly normal. We're seeing this great, that's exactly what you'd want to see. Well, guess what? Now we're no longer paying based on therapy, so presumably SNFs and home health agencies are providing what's necessary. The unfortunate part is that we're now paying on coding. And so if you pay on codes, guess what you get? Lots of coding. And that's exactly, we did a paper recently in JAMA Internal Medicine. My colleague Feng Li Gang was the lead author on that. And we found, guess what? Hospital coding remained perfectly constant for those discharged to skilled nursing facilities. No uptick. For those, however, who were going to SNF in terms of their coding by the skilled nursing facility, huge increase in coding. Still not as high as the hospitals are coding. So I think there's still going to be some in the SNF community that are going to say, hey, guess what? We're still coding below hospitals. But they're incredibly responsive. So we basically have changed therapy for coding. Very quickly, you asked about outcomes. Quality, we're not seeing any shift, but I want to put a big caveat around that. We're looking at claims-based outcomes. This is going to be a big theme of our discussion today, just the limited number of quality measures we have. We're looking, when I say claims-based, I mean mortality, I mean readmissions, I mean emergency department visits. We don't have the kinds of measures that maybe matter most, like long-term functioning, patient satisfaction, these types of measures. So I want to flag that issue. I know, Catherine, it's going to come back up. But,
it's going to come up again. Yeah, great. Thank you.
Sure.
So Tamara, in your research, you've examined consequences, often unforeseen or unanticipated, of payment policies for beneficiaries and caregivers. And in the debate over site-neutral payment for post-acute care, what are the advantages and where do you see opportunities, and what are the risks of sort of more unified post-acute care payment system.
Thank you, Catherine. First, I wanted to thank you for organizing this panel and getting this group together. Second, I should say, even though I am a current MedPAC commissioner, the views I'm expressing are my own, and I'm not speaking for MedPAC. Okay, about site-neutral payment. Site-neutral payment is conceptually really appealing, almost self-evident, right? If services are provided in two different sites and patients get the same outcomes from those services, that same service, then we should be paying the same thing, right? We shouldn't be incentivizing through higher payment treatment in one site over another. The problem is, and that of course would save Medicare money, right? Which is a great goal. The problem is that in practice, it's a lot more complicated, and it's complicated because of sort of unmeasured aspects of health in the patients that are going to the different settings, right? So I'll use IRF versus SNF as an example, but one could say the same thing, perhaps even more dramatically about the sort of SNF versus home health margin. So there are patients with conditions that could be treated in an IRF or in a SNF, right? And we pay IRFs a lot more per stay for the therapy that's provided in an IRF. And in part, that's because the therapy is really intensive. Patients are required to be able to withstand and benefit from at least 3 hours of therapy per day, 5 days a week, right? And so for some patients, that may be really good, and they're going to be better off. But the problem is discharging hospitals are going to look at patients and see things that we don't see in the data, right? They're going to look at the robustness or frailty of that patient. They're going to look at the motivation of that patient, maybe the family support, and they're going to decide who can really benefit from an IRF. And those same qualities that we don't measure well affect that person's outcomes regardless of the treatment they get, right? And so the research is just really behind our ability to do site-neutral payment well in the post-acute care world, right? And if we sort of base policy and move towards site-neutral payment without sort of accounting for that selection bias, then we run the risk that people really who could benefit from that therapy are not going to have access to it, right? So that's the downside of not having great research on this. We did a recent literature review looking at all the studies that compared SNFs versus IRFs. We found 31 studies, not a clinical trial among them, right? So these were all sort of observational studies. And mostly these studies were small, single-site studies that did not deal well with this selection bias that I was just talking about. There were 2 stronger studies that used a combination of instrumental variables and propensity scores only among stroke patients, and did find better outcomes among IRF patients who could have gone to either SNF or IRF. So there's some at least strongly suggestive evidence for this one group of people, right? So my conclusion from all of this is that site-neutral payment is really a valid goal. It's in the news a lot in other sectors right now, right? People are talking about it a lot in terms of physician offices versus outpatient departments, where the same goal exists and some of the same complications. But I would hope that we could return to this in post-acute care. But I think before we really start changing payment policy, we need some better research on more conditions, and be really great if we could throw in a clinical trial as well. Thank you.
Yeah. So now I have a question for you, Anne. Your research has focused on outcomes and quality in post-acute care across all the different settings. What are the key dimensions of the quality and effectiveness of post-acute care? And Tamara got to some of this, but where do we have good evidence, and where do we need better evidence on the quality of post-acute care?
Great. And I will do my thanks for the invitation to speak also. A pleasure to be here. I think I'd like to make a couple of points. So the first point is that we do have quality measures that are globally important. So for example, readmissions, patient safety measures. But I'd also like to highlight that the reasons that people and goals for post-acute care can vary a lot for the patients receiving post-acute care depending on their medical condition and the severity of those medical conditions. So for example, in home health, you have a group of patients who are there for medication management and teaching, and so quality measures for them that are particularly appropriate in terms of effectiveness of the services targeted to those patients with those needs would be emergency department visits and readmissions. For a patient who is in a long-term care hospital who is on an invasive ventilator, ventilator weaning would be a really good outcome measure specific to that population. There is a big group of patients who need rehabilitation services in post-acute care, and Tamara touched on stroke as one example of a very significant diagnosis, many people with that condition. And so for those patients, improving function is really important, improving discharge to community so that people are not being admitted into nursing homes or not going home and being needing significant care from their family members in terms of caregiving. Also improving quality of life of those individuals who are going back into the community or in some cases going into nursing homes. So what second point I'd like to make is within the rehabilitation patients, there are people who have conditions, for example, orthopedic conditions, and for them, the recovery is about strengthening and making sure they are safe going home, whereas for somebody with a neurologic condition such as stroke, traumatic brain injury, traumatic spinal cord injury, or even a non-traumatic brain dysfunction or spinal cord injury, the intensive rehabilitation has been shown to improve outcomes. And that's in part because for the neurologic patients, what is happening is all that repetition is helping to rewire the brain so that somebody's able to do those activities. I think the research is lacking for sure. I think for traumatic brain injury and traumatic spinal cord injury, there's a little less research because not all of those patients actually go into every facility, whereas probably almost all SNFs, almost all IRFs will admit patients with stroke. So there's limitations to data, limitations to some of the studies, for sure.
Great, thank you. And I want to continue on this topic, actually. So you've kind of mentioned that depending on your condition, you have different goals of your care and different things might matter to patients. But both SNF and home health operate value-based purchasing in their payment systems. And what do we know about whether these programs are improving quality for patients? Tamara, why don't you start? And then, yeah.
So value-based purchasing is another one of these approaches that, of course, is not limited to post-acute care. We see value-based purchasing, over the last few decades across the entire healthcare system. And if I can sort of grossly generalize, I think a lot of the evidence from value-based purchasing across those different sectors is just a little underwhelming, right? Like it's sometimes, we get a little bit of savings, sometimes we get a little bit of improvement in quality. It's never a panacea. And there's a lot of focus on were these actually well-designed programs or not? Are the incentives big enough? Are the quality measures appropriate for these? So in home health value-based purchasing, I'd say the evidence so far is very much along those same lines, right? There are a handful of, actually there's something like 14 measures that are reported and used in the value-based purchasing program, different types of measures, so that's a good thing. It is designed to be budget neutral, so there's a withhold of payment and then it gets redistributed to home health agencies depending on their performance on those measures. And what researchers have found so far is that there's a little bit of savings, mostly from reduced readmissions to the hospital and reduced admissions to nursing homes. and not much difference in quality. Maybe some improvements on some of those measures, right? So again, kind of underwhelming, but probably well worth doing, like putting these quality measures and the sort of cognizance around these savings into practice. The SNF value-based purchasing, on the other hand, was just really badly designed. And I won't say much more than that because David actually did the evaluation of it, and he's going to talk next.
Yeah, I get to pile on there.
I will let him discuss the details of the SNF value-based purchasing program and the problems and how it might be improving. But I want to just turn for a second to this perennial problem across all of these value-based purchasing programs, this problem of the role of resources and socioeconomic status, right? Again, not specific to post-acute care, but we see over and over, for example, that the SNFs that are penalized, and actually the majority of them are penalized under this program, but the SNFs that are penalized under value-based purchasing tend to be those with a high Medicaid census, lots of duals, located in lower income neighborhoods, et cetera. And it's a real challenge because one can't ever really separate true deficits in quality from poor performance on these measures due to inadequate risk adjustment because their populations are just sicker or because they have fewer resources, right? So we're never going to be able to separate that cleanly, but it does present this practical problem that all of those facilities, and the same goes for home health agencies serving lower income populations, we're probably never going to be able to incentivize them to invest enough resources to improve quality, right? So this sort of contributes to the overall sort of underwhelming evidence that, value-based purchasing is probably a good thing to do, but it's not going to solve some really fundamental problems of low-quality nursing homes that are under-resourced and where, many lower-income individuals go.
So I agree with her two big themes there. One, the evidence has been super underwhelming, and two, this is still an idea that I think it's not going to solve everything, but there's an opportunity with value-based purchasing. So Tamara teed up, I was one of the evaluators on the SNF value-based purchasing demonstration. We didn't find anything. And they actually did do a randomized trial, if you remember. It was 3 states, and they randomized some nursing homes to get this reward payment if they achieved a broad set of quality measures. They rewarded improvement. They rewarded absolute performance. It turned out it didn't move the needle. And all the problems that Tamara mentioned were present there. The pennies for performance, there just wasn't enough dollars at play. It largely rewarded facilities, it turned out, that would have been good anyway. The government just gave a financial incentive. They didn't really teach nursing homes how to produce better quality. I could go on, just a series of challenges. So based on that underwhelming evidence that we put together as part of this randomized trial, they actually went ahead and rolled out the program, which was great, but rather than trying to build on, I think, some of the lessons that we learned from that evaluation, I think they went the opposite direction with the SNF VBP that's now in place. And there, as Tamara mentioned, there have been some steps to try to improve it. Some of that's been driven by criticisms, I'm going to be biased here, that MedPAC has made, and I think really good criticisms that have moved the needle there. But there's still a lot of work to be done. I mentioned in the original kind of demo that we evaluated, it was a really rich set of quality measures. Now it's very narrow. So it's just readmissions is the only measure in the program right now. And that's, readmissions are important, we all know that, but they're one of many dimensions of nursing home quality. And we know there's a lot of work to be done on nursing home quality. Great that they're focusing on readmissions. we did a study, found exactly what Tamara described. Rather than trying to equally reward facilities, it turned out this was widening the gulf between the haves and the have-nots, that it was kind of disproportionately rewarding facilities that had fewer Medicaid recipients, that had more resources. And so the rules of the game here aren't fair. So as I said, there's been some steps to try to level the playing field and correct some of these issues, but I still don't think we're there with the SNF VBP, and part of it is that we're measuring it very narrowly, and I don't know that we yet have the right incentives, but I will say quality is such a huge issue in this space that I think I like the idea of running lots of experiments, lots of let's get lots of shots on goal at this issue. I'll note Tamara and I were part of a National Academies Committee in 2022 that put out a report on nursing home quality. If you go back a lot of years before it was the National Academy of Medicine, it was the Institute of Medicine. In 1986, they put out a report on nursing home quality with almost the same title that we did in 2022. So lots of years apart. We haven't made a lot of movement on this issue. Judy, you can support me on this. We have and we've all been doing a lot of work. We've been pushing that rock up. I know a lot of us. That's my joke. The next report the National Academies do, I'm going to be at a nursing home. They might survey me as part of it. So there's a real challenge here, and so I like the idea of trying lots of different things, but we're not there yet with value-based payment.
When you were talking, it was making me think of Anne's comments and like the variety of things that matter to patients and the goals, and then it's how do you go from that to one measure.
Readmission.
I mean, I know the SNF VBP has more measures being added to it, but it's a big gulf between what matters and what we can measure.
Absolutely.
Thank you. So I wanted to turn to a different topic. We've been talking, I presented data on traditional Medicare spending, utilization, and we've been talking mostly about traditional Medicare, but of course, more than half of Medicare beneficiaries are now enrolled in a Medicare Advantage plan. And what do we know about post-acute care access and use and outcomes for beneficiaries enrolled in those plans? And what's the evidence on spillover of practices onto traditional Medicare? So David, I know you just got done talking, but I'd like you to start.
Sure. I'll kick us off here. Medicare Advantage plans have really clamped down on post-acute care use. So every study, and once again, it's not, some of the studies are better than others. We can't randomize somebody to Medicare Advantage, and so there's some challenges with the research, but everything we've seen suggests both in terms of absolute overall use or conditional on receiving services, the amount of use, so the extensive margin and the intensive margin, both quite a bit lower in Medicare Advantage relative to traditional Medicare. There's a lot less access, and there's been a lot of questions, especially recently, about how Medicare Advantage does that. And we have a study, for example, we started out, we thought we were doing a staffing study, and it turned out we were doing a Medicare Advantage study, and that we observed in our data that hospital length of stay is going up. And we thought this was a SNF problem. Nobody can find a bed. There's just not enough staffed beds. Turned out that wasn't really what was going on. Most of that increase was Medicare Advantage. It still may be part of this, maybe staffing, but a lot of that could be prior authorization. Medicare Advantage is sitting on these individuals in the hospital rather than discharging them. So I do think prior authorization is really important in this space right now, narrow networks. Medicare Advantage has a lot of tools. Some of them may be good towards limiting kind of use of post-acute care, but some of them may be leading to unintended outcomes right now, underuse of post-acute. And I'll say finally, and then this is once again in that theme of, you asked again about outcomes. No difference in terms of outcomes across traditional Medicare and Medicare Advantage. And once again, that's consistent with two explanations. First, there's no difference, but Second, maybe it's also consistent that we're not looking at the right quality measures. And to Ann's point, what matters to Medicare beneficiaries? We have great claims-based measures. Those don't show a difference. Much harder to measure long-term functioning, satisfaction, quality of life, these types of outcomes.
Thank you. Tamara, do you have anything you'd like to add?
Sure. Let me start by saying I think this MA versus TM issue goes back to a sort of bigger problem in post-acute care, in that there is an incredible amount of uncertainty about the value of post-acute care, and certainly about the value of post-acute care in different settings, right? And there's been some good research on it for many decades. I think Melinda did some of that, some of the pioneering work trying to look at outcomes from post-acute care, several decades ago, right? But I think there's still a lot of uncertainty, and there's research showing, for example, that variation in post-acute care is the single biggest driver of geographic variations in Medicare spending, right? So some places just use more of it, some places use less of it, and nobody can figure out if it makes a difference, right? And so we kind of start with that, in that it makes this comparison between MA and TM pretty hard, right? Because we're sort of starting over every time to sort of figure out, like, are outcomes really different? What's this value equation when you restrict this use and when you don't restrict this use? Certainly there's a lot of anecdotal evidence right now, lots of newspaper stories coming out about sort of people not in MA not getting access to a SNF at all, or getting access to a SNF but being discharged and not getting access to the length of stay that they think they need. That's all sort of anecdotal, and makes people really worry about what's going on in MA. Part of what David was talking about, people staying in the hospital longer, just makes the story even more complicated, right? But to me, I think I have the same sort of summary of the literature, which is we see MA decreasing the intensity of post-acute care. There are studies using natural experiments showing, for example, that if you were in TM and you would go to an IRF, if you're in MA, you're going to go to a SNF. If you would go to a SNF in TM, you're going to go to probably home health in MA, right? And that outcomes that we measure, like rehospitalizations, don't really seem to matter that much. And so, I think sort of in contrast to the newspaper stories, we have to try to sort of keep an open mind about this, because given the uncertainty about the value of this care, this is a sort of grand experiment, right? Like, we can really learn a lot from what MA plans are doing, even if there are obviously some bad cases of denials of access, but we can really learn a lot from what MA is doing. And I just hope we continue to do the research, and there's some sort of data gaps from MA that we need to keep working on. Like, we need to keep pressing for better and counter data so that we can really compare these outcomes well, and sort of push this research forward to see if MA has actually got it right in some cases.
I mean, some of what you were just saying about MA also applies to bundled payment. You saw the same kind of like less IRF, less SNF.
No change in outcomes.
Right.
Claims-based outcomes, right? Yeah.
And I'd like you to speak to the ability of existing patient assessment data or claims data to help us understand these outcomes in fee-for-service versus MA. And what additional data, Tamara mentioned the encounter data, but what additional data would be needed to make good comparisons so we have the same information about both populations?
Great, happy to address that. So in post-acute care, as many of you are probably aware, there's assessment data that are submitted to CMS. And so the MDS, of course, is in the nursing home, skilled nursing facilities. The inpatient rehab facility patient assessment instrument is the IRF version. And then the LTAC care data set is kind of a newer one that's for long-term care hospitals. And in home health, it's the OASIS. So as part of the IMPACT Act, the data elements on those assessment instruments have been standardized. It's not perfect, but that's something that I think has been an important issue that has been addressed in post-acute care over the recent years. And I just wanted to highlight that in the long-term care hospitals, those assessment data are collected on all patients regardless of payer. So there would be the ability to compare traditional Medicare and Medicare Advantage. And that's data that's been collected since about 2012 or so, and again, more recent data on that data set. The inpatient rehab facilities recently went to all payer. They have been actually Medicare, both fee-for-service and traditional, and the Medicare Advantage since I think about 2015 or so. But they also went to all payers, so there's the ability to even look at other payers with the IRF-PI data. In the skilled nursing setting, it is still only Medicare fee-for-service. So that's a limitation there. In terms of the claims data, the encounter data for Medicare Advantage, I know CMS has been updating some of their readmission measures in acute care to encompass both the fee-for-service claims and the Medicare Advantage data. I will note that actually MedPAC had done some analysis on this and found that, one, there are some coding issues. So this goes back to a comment David made some time ago about if you're paying based on coding, you're going to see coding change. And also there was some missing encounter data. So there's definitely some challenges there, going back to Tamara's concern about research. I did want to highlight there was one study by Amit Kumar who did look at claims and encounter data for patients who had had hip fracture, and he compared SNF in SNF settings, and he actually did find, and his methods were fairly good, but probably not as good as we would like them to be for various reasons. But he did find that the Medicare Advantage patients actually had lower length of stays, higher discharge to community, so that's a favorable outcome, and also lower readmission rate. So the question is that a coding effect that the Medicare Advantage patients maybe, there was an appearance of them being more acute than they truly were, or were they healthier? Was there selection bias, which Tamara touched on? So I think, again, another area for research.
Great, thank you, Anne. So I want to switch to ask you, now that we've kind of talked about quality, we've talked about access, we've talked about some of the refinements to the payment system, we've talked about maybe unified post-acute care, we just can't get there yet. So I want to kind of pull some of these things together. And I'd like to ask about priorities. So if policymakers, need to choose, and maybe you reject the premise of the question, but if they need to choose between, refining the way traditional Medicare pays, scaling bundled payment, expanding bundled payment, or other alternative payment models, maybe advancing site neutrality, maybe just Medicare Advantage for everyone. What path should take priority and why? Or is there some kind of smaller scale thing within the payment systems that you think would make a big difference, like measuring function or better quality measures? So David, why don't you kick us off and sort of give us your kind of wish list, priority list, based on whatever criteria you want.
So I won't reject the premise of your question. I'll take it on.
Okay.
I will give a priority here, and I think I'm going to put Medicare Advantage for all off
Sure.
the table. I think that just
Sorry.
that might break my brain this late in the day.
That's fair. That's a lot to.
But thinking about the other options you put forward, refining the existing PPS or site neutrality are still sort of built on the fee-for-service they're really fee-for-service models. And so I still like the alternative payment models. That would be the priority. However, post-acute care really hasn't been a part of the, I should say this a little differently. Post-acute care has been included in these models in the sense that spending has been part of the model. The problem has been, it's been the real source of savings. So we wrote a NEJM perspective a few years ago just called post-acute care is the piggy bank for all these alternative payment models. And it's really true. Like that's where the savings were. You cut, as we've been discussing, the intensive margin, the extensive margin around post-acute care spending, that's where the savings were coming from, not hospital spending, not physician spending. So I think those kind of models, alternative payment models, are great. That's the area we should be thinking about. I just worry that when it comes to post-acute care, they're not part of the sort of team here that's producing care. They're the ATM here. We're just going to cut services and kind of pull them out. And so I'd like us to kind of think more broadly. There are models, and I'll be curious if Ann or Tamara agrees here, but it's not a post-acute care payment model, but there are institutional special needs plans and other models that actually engage nursing homes and other post-acute care settings. And so I would like to kind of shift the discussion away from sort of models, alternative payment models that simply pull spending out of post-acute care. That's not a bad thing. I think that's so far, it's I guess you could view it as high value and that we haven't seen a decrease in quality. But once again, we'd want to think about quality more broadly. And I want to shift the conversation to how do we think about delivering this better? What are different ways of paying for it outside of site neutrality or just making tweaks to the patient-driven payment model or the groupings model? So that's where I would like to see us put our efforts.
Great, thanks. Anne, why don't you
Sure.
give us your wishes?
Sure. So I think for like bundled payment, I think makes sense when you have a sort of heterogeneous population. So for example, like joint replacement that is, not the emergency hip fracture situation, but planned surgery, I think where there's kind of a predictable trajectory, there's been kind of equal outcomes shown in various studies. And so, a bundled payment for that population makes sense to me, and that has been implemented. I think it would be harder for bundled payment for a group with a more heterogeneous population, for example, stroke, where you have varying levels of severity, paralysis, swallowing problems, communication problems, and those can get kind of expensive and unpredictable, and so I think that makes it kind of risky to do that. For the unified post-acute care, I think I agree with what Tamara mentioned earlier. Without knowing the outcomes, I wouldn't feel comfortable that, implementing the same payment, but patient might have different outcomes. And I think, one other important point that David talked about that has been incorporated into the bundled payments is looking at the longer term outcomes. Because right now in post-acute care, when we look at functional outcomes, we look at function at discharge. But what's really important is that person going back into their own home and, maybe they learned how to mobilize in a wheelchair in the IRF, but at home, they don't have a bathroom doorway that allows their wheelchair to go in. That's a problem. And so making sure that people are able to function in their own home and therapy targeted to the function needs that they have. And, in post-acute care, our assessment instruments have distances of 150 feet. That's not really a magic number, but if somebody, has a smaller room and needs to go 200 feet in order to get to their bedroom, like that's the distance for them that we should be working towards. And so I think, without having some of this quality, it makes it really hard to think about some of these payment models for me.
Great. Thank you.
I would focus on a couple of things. One, I'll expand on David's mention of the ISNPs, the Institutional Special Needs Plans. I think that, in some sense, it's an oversimplification to think that we're just talking about post-acute care, because certainly for SNFs, nursing homes, the distinction between payment for post-acute care and for long-term care is very, very blurry, right? A little bit clinically, certainly in terms of the payment and the flows of funds. I'm very excited about ISNP models because it's the only thing we've come up with after all of these decades that actually tries to get rid of some of those bad incentives in nursing homes where long-stay residents get hospitalized and come back through on post-acute care, right? It's the only model that, at least by design, is designed to is intended to address that. And so there's not much evidence on ISNP so far. What's there is a little inconsistent, but I would love to see us build up that model and learn more about the intended and unintended consequences. And maybe in conjunction with some of the other alternative payment models, like when possible, extending bundle payments for those people who really truly are like the joint replacement people who might come through a SNF temporarily and fully intend to go home, right? So the combination of those two, I think, is a promising avenue. The other thing I'll mention is sort of on the other end, which is this IRF versus SNF nexus that I was talking about earlier. I've gotten really fascinated by that and the idea of sort of identifying the margin of value between IRFs and SNFs, and perhaps with the goal of moving towards site-neutral payment on that margin. I've gotten fascinated by a lot of numbers that MedPAC has come out with. So even though, you saw from Catherine's graphs that, IRFs are still a small part of post-acute care, it is 16% of post-acute care funding now. But what's really shocking is the growth.
Yeah.
And so we have seen this really rapid expansion, especially of for-profit freestanding IRFs. Just between like 2020 and 2024, so there was a 25% increase in the number of IRF stays. That's big. Among these rapidly expanding freestanding for-profit IRFs, profit margins are around 24%. Right? So on average, we saw from the slides, again, it's around 15%, but in these for-profit freestanding IRFs, it's 24%, whereas in the sort of more traditional hospital-based IRFs, it's 1%, right? And freestanding facilities are now 61% of all IRF admissions. And more interestingly even, a lot of this is due to the expansion of one single company, right? Encompass now has 44% of all freestanding IRFs and accounts for a third of all traditional Medicare IRF stays. And so those to me are just kind of shocking statistics, and they also, these freestanding facilities seem to be attracting or coding people into like the most profitable conditions, right? And it's sort of disproportionately people with cognitive impairment getting admitted for other neurological conditions. So all of this to me says that, we are nowhere near site-neutral payment, and perhaps we need to take a really close look at what value we're getting for that huge expansion, which is almost certainly driven by high profit margins. And so that's what's really fascinating me lately, and what I think a good next step in post-acute care research would be is to really take a closer look at IRF versus SNFs.
Great. Thank you. I'm trying to decide whether I want to address some of these things.
You're going to solve it right now.
I kind of want to ask a follow-up question, and I think this touches on some things that you are all saying. So, bundled payment, very appealing. I guess I'm going to identify myself as sort of like but what about these traditional Medicare payment systems that everything's built on top of and that nobody really is that interested in studying or doing much with because it's just kind of, I don't know, boring, old, not a bundled payment, not these more exciting things. I'm not putting this on you all, but I do worry though, like, let's say we've learned a lot from MA or bundled payment about, oh, you can reduce care and nothing really seems to get worse or the outcomes seem to be the same. Maybe we're not measuring the outcomes right. But what do we do with that information? Do we take that back to the traditional Medicare payment systems and make some changes to those so there isn't this opportunity to save in bundled payment or save in MA because we just take it out of the rates? I'm just like, do we ever go back to traditional Medicare and say, let's do something about these payment systems? Or has everyone moved on? Even though we build everything else with these building blocks, has everyone just moved on and we're not going to do that anymore? You don't have to answer that question, but it's something I think about. It's something I think about. So, and if anybody else, when you're writing down your question, if you want to, say that's a crazy, stupid question, go ahead. I might not read it, though, if you do write that. So we have a kind of panelist to panelist portion of the program. And so I'm going to give our panelists the opportunity to ask each other a question. So I think, Tamara, you're going to kick us off, right?
Okay. Yes, and this question is for Anne. You've talked a lot about measuring function in post-acute care, which is obviously challenging but fundamental. Do you see technology, for example, digital tools to measure functioning as a solution to solve some of these measurement challenges?
I think it has possibility. I actually have spoken to a colleague, Megan O'Brien, about what they're currently doing to think ahead to this. Because David touched on coding. You tell people you're going to get paid based on coding, they will pay attention to their coding. So there's definitely some issues with the current functional assessment data in terms of incentives to code that data. And so wearable sensors have been developed and are being tested. They currently are being tested measuring things like 6-minute walk test, things like that, to get a sense of how well somebody is functioning, at least in the walking area. And that's a good measure of function. It's not exactly aligned with the way that function is measured in post-acute care in terms of level and amount of assistance required. So Megan is working on creating a toolbox, and they call it Automate, Illuminate, and Predict. And what they're trying to do with these sensors is to apply the sensors to the patients. And of course, there's issues about people taking showers and getting them wet and all those. So there's a lot of logistics that go into all this that I won't get into. But just to say, there's lots of challenges. And she's working with clinicians, so it's co-designed with the clinicians and making sense to the clinicians in terms of what data comes out. They are using them on patients with stroke primarily, and they are trying to automate the data, obviously, so that the wearable sensor gets this output about how well the person's doing. It also highlights what impairments these patients are experiencing so that clinicians can actually use that information to target improvement of functioning. So it is more useful than even the data because it's actionable data. And they have, they're creating dashboards so they can get the output. And then the goal is to predict function for these patients also based on the data that's collected, not only by discharge, which can help with discharge planning and caregiving, things like that, but also in the longer term, which I know, David, you talked about. We should be worrying about function and not at discharge, but in the future. And so that's what they're working on. So does that address your question? Okay.
Thank you.
Great. All right, so I think it's my turn next, and I will be asking David a question. I was wondering if you could address the issue of workforce, and in particular, things like immigration and staffing shortages, and how that's affecting quality of care in post-acute care and or long-term care.
Yeah, no, this is a great topic to include in this discussion, and we haven't touched on that, but I think it underlies everything we've discussed, that every setting from home health, which probably has the highest share of labor, but even if you go to LTECs, labor is still their dominant input. It's important across all four of these settings, and just given the demographics, we're going to see a lot more older adults who use post-acute care, a lot fewer individuals able to provide that care. So we're really seeing the sort of a tipping of the scales here, and I think what's good, it's sort of an all hands on deck set of solutions where we need to think really broadly about both growing the pool of native-born workers, but also foreign-born workers. So let me say, and all of the, I'll talk specifically about immigration policy in a second, but both groups, we need better pay and benefits. We need better working conditions. We need career ladders. We need to make this a better job where we're not. It's not a hierarchical workforce. We're giving the workers autonomy and valuing them as important caregivers. So we need to do all of that across the board, and there are a lot of good strategies around trying to build this workforce, from increasing minimum wage laws, wage pass-throughs. I don't know if I should say this one, minimum staffing standard. we tried in nursing homes. We didn't get there. Maybe it'll come back. But a lot of different approaches to try to grow the post-acute care workforce, either in a particular sector or across the board. So the other part, Anne, of your question was about immigration, and we've been doing a lot of work on this issue. It turns out it's always been hard to recruit individuals into the post-acute care workforce. It got harder following the pandemic. And what we found is, at least in nursing homes, a lot of native-born workers left the profession. The individuals that stayed were largely foreign-born caregivers. I'd like to say, where would we be without them? And I really mean that broadly, not just in this period following the pandemic. We have a paper that's in press at the American Journal of Health Economics, where we look at when you have a shock of immigrants to a particular area, what happens in terms of nursing home staffing and ultimately quality of care. Turns out inflow of immigrants leads to more individuals working in nursing homes, which leads to better outcomes. And the effects we're seeing are about the same as a pretty sizable increase in Medicaid payment rates. So you're getting just as much as you would get from increasing your payments as you are from increasing immigration. And the great part about the result, no decrease in wages for native-born workers. It's just increasing the pool and not competing down wages. So, and quality's going up. So it's a win-win-win, yet our current policy right now is not leaning in that direction. That may be an understatement. We're not pushing towards increasing immigration. We've had a very, what I would call, non-uniform policy, in that it's almost been haphazard around immigration. A lot of the individuals working working in post-acute care are here through asylum or through family reunification. They're not here through particular visa categories. So we could be a lot more intentional about how we increase this workforce. There's so much opportunity here. Once again, that's not the discussion that we're having. We're having, I think, a decrease in potential immigrants willing to work in post-acute care. And then even if we're sort of decreasing slots, there's also kind of everything is, I think there's been a spillover here, chilling effect of individuals even wanting to immigrate here. So this is an issue, obviously, I could go on for a long time about, but I think there's such an opportunity here. And that last thing I'll say on this, and then I'm going to ask Tamara a question, I promise Tamara. This isn't an either or. Once again, like people sometimes say, well, you're talking about immigration as a substitute to growing native born. No. Everyone needs better pay. Everyone needs better working conditions. All the opportunities here. You're not doing one at the expense of the other. We just need to do both. All right, my question. That's enough of that. I'll get off that soapbox. Tamara, one of the areas you've studied that I really have enjoyed your work has been around quality report cards. And those are used in the different post-acute care settings. And I'm wondering if you could say a few words, kind of where we're at with post-acute care quality measurement through all the Care Compare and all the 5-star systems. And then what's missing? Like how do we build on what we currently have?
Great. And I think spending a lot of time talking about workforce is just fine.
Yeah, right.
It's just sort of fundamentally important to everything we've been talking about. So public reporting in post-acute care and especially in SNFs, which I've studied for the last 25 years or so. I'll first say that, it's comes under a lot of criticism, the Nursing Home Care Compare site, the 5-star system. And, it's criticized for some really good reasons. But I'd say my sense after, looking at this and studying it for so many years is that overall it sort of passes the sniff test, almost literally.
No
right?
pun intended there.
When you go into a 1 or 2-star facility, you kind of like, yeah, that makes sense, right? And you kind of know when you go into a 5-star facility, and that makes sense. There are other things, the difference between a 3 and a 4, certain parts of risk adjustment, gaming of some of the MDS-based clinical quality measures, those are all certainly problems. But the overall system, I'd say we're better off for having it than not. But I'd say there's 3 main ways in which it could be, I think, tremendously improved. And this is something that, I've concluded after doing a review of all the literature out there on Nursing Home Care Compare, but this is also what our National Academies report concluded. This is not just me saying this. I think there's general agreement about it. But one is the Nursing Home Care Compare, as opposed to home health, which has patient experience measures, Nursing Home Care Compare does not have any patient experience measures. It has been through the last decade of sort of planning and controversy about which system should be used. The CMS was intending to implement it at some point. Didn't happen for reasons that are still a little bit mysterious to me. I know part of it was sort of fighting over which system, the CAPS versus the sort of industry-developed system, which one should be used, and the resources for collecting that data. But in any case, consumers, when they want to find a nursing home and want to use a system like the Nursing Home Care Compare system, really need to know what others have experienced there. And it's a different kind of measure that we just don't get out of the administrative measures we have. Another area that's really missing is end of life. Other people have written about this, but we don't really have a lot of good information in that system about end of life care. But the most important one to me circles back to workforce, and that is when Nursing Home Care Compare was started, the data we had on nursing home staffing was really bad. It was the Oscar and now Casper system that was based on one point in time every year for each facility around the time of their surveys. Nursing homes would staff up during that time. Nobody really trusted this data, right? But since 2017 or so, we have the PBJ, the payroll-based journal data, the staffing data. It's incredible, right? Like, we know on a daily basis how many staff are in the facility, and can calculate now measures like turnover that have been added. So the addition of that data has enabled CMS to add quality measures on staffing beyond sort of basic, sort of improve the validity of those measures and add measures, right? So we have turnover, we have weekend staffing, we have all kinds of stuff like that. But staffing is everything in a nursing home, right? Like, this is something that everybody agrees on, right? Yeah. Like, people in here are nodding their heads, but the provider community agrees that staffing is sort of fundamentally important. Policymakers believe that, researchers believe that, consumers believe that, the staff themselves believe that, right? And so why, now that we have good data, does the staffing component constitute still such a small part of nursing home care compare, right? It's still, there's about a 90% correlation between the inspection measures and the overall ratings, right? It's still all based on the inspections, going back to, like, that was the most valid part or reliable part when nursing home care compare was started. But we need to just start over and increase the weight of the staffing part of it and sort of decrease the weight of the inspections, because that's really what people need to know when they want to know about quality in a nursing home.
Great.
That's great. Should we collect the questions for? Thank you. Thank you, Linda. Okay. Thanks.
Can you read everyone's handwriting?
No.
Oh.
That's going to be a big factor in which questions get asked.
You have good penmanship
Yeah.
here. So.
Okay, there's 3 of this question, so I'm going to ask it. If the panelists would recreate post-acute care payment from scratch, what would you do?
Do you want me to start, or like?
Yeah.
Maybe that's not a good thing, because I tear down whatever I say. But I think sort of the architecture would be around something more site neutral. It would tear down a lot of the measurement that we have. Ann did a nice job of describing the different assessment instruments, and the big problem there is they're provider reported, so we can't kind of trust that information in the IRF-PI and the MDS and the OASIS. I'll just use an example. MedPAC every year does the report to Congress where they document SNF quality, and they don't include any of the MDS-based measures or the OASIS-based measures or the IRF-PI because they don't trust them. And we've got to do better there, whether it's auditing, oversight. So I would switch to something more site neutral that has a quality component in it, and then get the quality measurement right here if we were tearing this all down, where we could actually track quality in a more accurate way.
I guess I'll add to that. So, I have kind of the most experience with the IRF payment system, and I do like the way that's designed, where the patient's condition and severity is kind of the driving force, and that's kind of the driver. And the update to the home health payment system did sort of align to that. The SNF not as much, but I guess I do feel like knowing somebody's condition and like the trajectory of that based on the severity, I think is important. So I guess I'm kind of tied to the assessment because that's, I guess, how it's been. I think I would like to see more auditing or review and more research on, the accuracy of the diagnosis codes and the function coding so that we can really believe in that.
Yeah, I'll add on a little bit by saying, yeah, clearly the sort of silos in different kinds of post-acute care, and each one having their own payment system, some episodic, some per diem, and each one having its own assessment system, just creates barriers now that are really hard to overcome. And so I agree with what David and Ann were suggesting in terms of we started over, we would try to do that uniformly across all of these sites. You know, I have a really hard time thinking about this question, maybe because I have spent so much time thinking about nursing homes, and that is like, there are these bigger silos as well, right? And so to me, it's not really enough to break down the silos within post-acute care. I strongly believe we need to break down that sort of long-term and post-acute care silo as well. You know, and then the Medicare, Medicaid silo that goes along with that long-term and post-acute silo. So, you know, to me, it's not just how would you start a new post-acute care payment system from scratch, it's how would you just sort of reform the broader healthcare system to not have these sort of artificial divisions, you know, have people have access to the care that they need, whether it's long-term care at some point and post-acute care at another point, you know, without sort of these Medicaid cliffs and eligibility cliffs.
If I could just add on to that, Catherine, like I'm so glad you made this point, Tamara, because it's something that really bothered me when I was on MedPAC of just like everybody in Medicaid that we were dealing with there, these long stayers in nursing homes were dually eligible. They were Medicare eligible, yet we could only think about post-acute care payment. And so we had this really weird setup where we basically were paying those huge margins Catherine had up earlier and on the skilled nursing facility Medicare side, yet paying a lot less on the Medicaid side, and just depending on things to kind of work out. And like anyone that looks at that, why would you ever set up a model this way? You wouldn't. This is broken. And so I totally agree with that. How do you sort of get those two pieces working together in addition to working across those post-acute silos?
Yeah.
And I guess if I can just add, I don't think any country has figured this out yet. There's certainly been, access issues and studies looking at the effectiveness of rehabilitation in post-acute care in Australia and the UK, and people have really tried to understand, what is that benefit? And I think, post-acute care in some ways is an investment in somebody's future and has the potential to reduce caregiver needs, to reduce, costs in the long term for the rest of somebody's life. And so there have been a few studies in the UK and Australia looking at it, probably not great methodology, but they tried to say, what is it worth to get this? In this case, they did inpatient rehabilitation versus no care at all. And they basically showed that the investment for patients, it was acquired brain injury, so stroke, traumatic brain injury population, and they said that you kind of recoup, you get, you offset the cost of post-acute care rehabilitation in about 18 months, and they looked at data to show, on average, people were living, this amount of time, and so there was an estimate generally, and, it would vary, of course, by condition and severity and all that, but they said, that care in post-acute care was on average saving about $1.5 million per person. So like the value of post-acute care is really important, but I think one of the other things that we haven't touched on, but MedPAC did a report on, is serial PAC use. So people going from a SNF into an IRF and then home health, and maybe there's an LTAC in there too. But the fragmented healthcare system, I think, is really a challenge.
Right. I'm struggling with the handwriting a little bit. I'm sorry. There was a question. I'm trying to find it, but someone asked a question. I can't find it, but it's something like, isn't unified post-acute care naive, right? And so I think, Tamara, you kind of addressed this in a way, because you and we just talked about it again, but the theory is right, and maybe if you were building a system from scratch, that's what you would do. But it's really hard to go from what we've got to that because of all of the unmeasured things, the inability to compare outcomes, the differences in patients, and then some of the things about what makes somebody successful, like whether they have a caregiver. And so I think to that question, I think naive is, maybe a bit judgmental, but fair.
I think you framed it well, Catherine. I think it's maybe it's the construct or the idea isn't naive. It's if we're starting from scratch, but it may be naive to think we could get there. And I think we learned that. We spent a lot of effort.
Right.
Anne wrote lots of reports on how we do this. You were working with MedPAC. I was we spent a lot of time thinking about this and didn't move the ball that far down the field.
And I don't want to stray too far from our post-acute care kind of. Focus here, but people might be really familiar with site-neutral payment. Tamara, you raised this in the context of ambulatory care, and I mean, if we could just for I think the sake of clarity, maybe talk about why that may be more viable than this, and I think, and you might disagree, right? First of all, somebody might disagree and say that care must absolutely be provided in a hospital outpatient department, but it's maybe the product is a little more uniform across, the settings, the differences in the patients.
So I don't actually think it's easier in hospital outpatient departments versus physician offices, and the same kinds of issues come up. There are these kinds of patients who really need that proximity to the hospital and the extra sort of staffing that might be around in the hospital, and those are kind of things that we might not see in the claims data. So, I mean, I wouldn't want to say it's a lot easier. Maybe it's a little harder in post-acute care, but I'm not sure. Okay. I think my answer to that is, to this question about whether or not this is naive is, from the perspective of if we were starting from scratch, are we going to get to that, what we would build if we were starting from scratch? Probably not. But to me, it's a case of okay, let's not let the perfect be the enemy of the good, right? We can make inroads. I think it's well within possibilities to sort of identify types of patients, types of conditions that are on that margin of either going to home health or going to SNF, right? And that we can derive some savings from Medicare, and patients will not be worse off, right? And same thing with the IRF versus SNF margin. And maybe, and we can certainly measure things better across settings and get rid of some of those silos. And I think maybe that's fine, right? Mm-hmm. We won't get all the way there, but I think we can still do a lot.
Mm-hmm. And we have done it in places, possibly in MA, in bundled payment, so it is happening. I do wonder, there are like bundled payment, and you were talking, Anne, about it works for homogeneous kinds of things. And I wonder how much of post-acute care is attached to those kinds of things versus, things like stroke, where it would be really hard to do bundled payment. That would be an interesting, how much can bundled payment get us? And are there things that are not bundleable? I don't really know. We sort of talk about it as a potential solution, but how big of a solution? How much of the problem could it fix? I think that would be kind of interesting to try to quantify. How are we on time? Okay. Let's do one more. There's an AI question. Can I ask it? I feel like it's essential to any conversation. what opportunities do you see for technology or artificial intelligence in post-acute care? And you talked about some of this with measuring function.
Yeah.
So I feel like you don't have to talk about it again if you don't want to.
Well, you'll give me a minute to think about
Can I
it.
ask you a follow-up question?
Yeah.
Like, to what extent do you think the research that you were describing is really scalable? Like, is this going to change things on a broader level?
I think it probably has the potential to be scalable. I know, there's some teams that have developed sensors that it basically knows when somebody is falling and literally, like airbags, inflates, something to protect the hips. And so, like some of these accountable care organizations can help on preventing some of the hip fractures and brain injury from falls, things like that. And so AI maybe can have a role in some of that, and the technology, because I think there's definitely potential there.
I think this is such a labor-intensive part of our economy that it's just really hard to imagine. Like, there's some role, we could certainly do a better job in post-acute care of leveraging AI and technology, but you're never going to see the kind of inroads you might see in other parts. It's just always going to require, I think, a caregiver. There are other countries, Japan, for example, has robot caregivers, and it turns out the studies I've seen suggest you need just as, they don't substitute for human caregivers, they complement them. And so, and I always tell this story, this is about a decade ago, somebody came by my office at Harvard, he wanted to show me his robot that was going to be in people's homes. I got very excited, told my colleagues, let's all meet down in the conference room, we're going to see the robot. Turned out it was an iPad on a stick, basically with 2 wheels, and it was very underwhelming. I think we've gone further than that, but I'm not certain we've gone too much further than that. So I'm optimistic we can do better, but I just don't think we're ever going to. It's always going to mean caregivers, and that's why going back to the workforce issues, that's so central here.
And I would. Oh, I'm sorry.
Oh, I was just going to say, there's robot pets, I know, too, right? Go ahead, Tamara.
Yeah, probably better than the iPad on a stick, though, I hope. It was, all right.
So I really am a little apprehensive about AI in post-acute care, and maybe I'm just a Luddite. I mean, I'll just admit that. I'm a Luddite about all these things. But I think the example I have in my mind right now has nothing to do with post-acute care, but it's the new WISER model that CMS put out. And they're basically, it's an experiment in using prior authorization in traditional Medicare, right? Which it turns out they've been doing a little bit of that for a long time, and I didn't even realize it till this model came out. But they're using AI to identify potentially low-value services that shouldn't be approved. And to me, this is really scary because of the problems in sort of identifying the value of post-acute care we were just talking about for a lot of this session. I would be really afraid that somebody will think it's a great idea to use AI to figure out where people should go for post-acute care and what should be paid for, right? So I am really worried about that. I mean, on the other hand, I looked at what CMS is actually using AI for in TM, and I'm like, oh, that makes sense, right? Because some of it's like skin substitutes and things where like the value is actually really controversial, right? And like maybe it's okay if somebody takes another look at that. But I'm really afraid of going too far down that road before we know what it's going to produce and before we just have a better handle on what we really think the value and the sort of comparative value of post-acute care is.
Mm-hmm. Yeah, and like not using AI to use AI, but like where is a good application? But I think, it's hard to see how you're going to replace caregivers. At least me, this person in 2025, cannot envision what that looks like. So I think we're going to end here. I want to thank you so much for your thoughts. I would attempt to summarize, but I'm going to give myself a little bit of time to do that.
So everyone come back in an hour.
I'm gonna go sit in a room somewhere while everyone's at the reception. No, I'm gonna think about this, and we're gonna post something about it. And but I appreciate everyone coming today. It's so nice to have everyone in the same place, and we can talk to each other afterwards about all of our thoughts and all of your questions that I didn't get to. I apologize. But please stay and mingle and talk. And yeah, so thank you all for coming. And thank you to the panelists.